Greetings and welcome to this module 2 on HIV management. In this video, we'll discuss about the treatment protocols, the post-exposure prophylaxis, and the commonly used drugs for HIV management, the opportunistic infections treatment protocol. This is completely for educational purposes. This is medicine beyond Harrison's. Let's get started. So, basic laboratory workup is mandatory before you start giving an antiretroviral therapy. So, if you are not sure about how to diagnose an HIV infection and when to start antiretroviral therapy, do watch the module 1 on this HIV series. So always check this complete blood count, fasting blood sugar, blood urea creatinine, serum bilirubin AST, and CD4 count. These tests are mandatory before starting the patient on antiretroviral therapy, as many of the drugs affect the liver and liver enzymes, the serum creatinine, and the blood sugars, the complete blood count. Also do a urine routine microscopy examination, chest X-ray to rule out pre-existing cavity or TB, cervical pap smear or alternate cervical cancer screening method before starting the patient on antiretroviral therapy. So additional tests are physician decisions based on the patient's pattern to rule out opportunistic infections including TB, metabolic screening, fundus examination if CD4 count is less than 100, expanded LFT for hepatitis B and C co-infection if present HBs, AG, anti-HCV, and syphilis screening if necessary. So anal pap smear for male sex workers also. So clinical examination, always look for jaundice, ulcers, lymphadenopathy, site size consistency in mating. For detailed understanding of the clinical examination first, do watch the module 1. For nutrition, detailed nutrition assessment is crucial. Malnutrition accelerate HIV progression. So always look for a respiratory system examination for crackles, any mass lesions, then cardiovascular system examination, CNS and abdomen for hepatosplenomegaly, ulcers, any swellings or discharges from the genital region. All these are very, very important to look for other common coexisting illnesses during the HIV infection. So CD4 count, when does it matter? It matters only for starting or stopping opportunistic infection prophylaxis, and also useful for differentiating advanced HIV, and it is not useful to start an antiretroviral therapy. So baseline viral load is not required for antiretroviral therapy initiation. The key principle is antiretroviral therapy should not be delayed. Now it is test and treat. That means all the test positive patients needs treatment. So overview of current ART regimen, it is a combination of three or more than three antiretroviral drugs. It is commonly used to suppress HIV to undetectable levels. With the advent of advanced antiretroviral therapy, there is a long-term, there is a high achievement of remission rates nowadays compared to the 2000s. So the benefits are immune restoration, slowing the disease progression, increased CD4 counts, lower risk of opportunistic infections, better quality of life and longevity, and reduced transmission. The viral load less than 50 copies per ml. Limitations: antiretroviral therapy cannot eradicate HIV due to latently infected CD4 cells. So it requires lifelong adherence to ART. So that is it. It is yet not curable. HIV can go into latent phase, but requires lifelong adherence to treatment. So principles, there are antiretroviral drugs act at multiple stages of the viral cycle. So it can act at the level of fusion to the cell, that is fusion inhibitors, CCR5 antagonist, Maravirac, and our reverse transcriptase inhibitors can be nucleoside or non-nucleotide reverse transcriptase inhibitors or integrase inhibitors or finally the protease inhibitors. All these are the 5 levels that an antiretroviral drug can act. So mechanism is entry inhibitors are enfovirtide, which is also the fusion inhibitor. Maravirac is a CCR5 inhibitor. Uh, nucleoside reverse transcriptase inhibitors are tenofovir, adifovir, zidovudine, didanosine, stavudine, emtricitabine, abacavir, and lamivudine. So non-nucleoside reverse transcriptase inhibitors are rifampicin, rilpivirine, nevirapine, dapivirine, and ertavirine. Protease inhibitors are ritonavir and darunavir. The integrase inhibitors are dolutegravir and raltegravir, of which dolutegravir is nowadays very commonly used, with tenofovir, abacavir is used, and lamivudine is commonly used. So basic principle is test and treat. Treat all patients with confirmed HIV regardless of the CD4 count. The counseling is essential. Adherence must be more than 95% to prevent resistance. Use a three-drug combination, preferably a fixed dose combination. Monitor therapy efficacy primarily with viral load. So first line is the NACO recommended TLD regimen, also the tenofovir 300 mg, lamivudine 300 mg, dolutegravir 50 mg. It is available as a single pill, taken once daily. It's a fixed drug combination. For adults and adolescents more than 10 years and more than 30 kgs, it is approved, including pregnant women. So don't stop during pregnancy. So alternate regimens depend on the age group, renal function, rifampicin co-treatment, and potential women of childbearing potential. So triple therapy prevents resistance by blocking multiple replication steps. Tenofovir Lamivudine and Dolutegravir, single pill, once taken once daily. Start ART in all diagnosed patients, irrespective of the CD4 count at the WHO stage, pregnancy category, TB co-infections. In case of TB co-infection, start ART within 2 weeks of starting ATT. Initially, start the ATT drug and then the ART to prevent immune reconstitution inflammatory syndrome. Why dolutegravir is preferred? Dolutegravir is recently approved and it is the most preferable drug nowadays because of the faster viral load suppression, better tolerance, fewer discontinuations, high barrier to resistance, and effective in HIV. So practical points of starting dolutegravir is it has a lot of interactions with antacids and iron. Give dolutegravir 2 hours before or 6 hours after giving an antacid or iron tablet. Metformin reduce the dose to less than 1000 milligram per day. Anticonvulsant avoid carbamazepine, phenytoin, phenobarbital. Rifampicin use alternative strategy instead of rifabutin. So in case of rifampicin, there is requires additional dolutegravir dose taken in the morning. Monitor diabetes, hypertension, and for tenofovir toxicity also. Weight gain monitored monthly. Side effects are minimal. Insomnia and headache and nausea are the main side effects. Tenofovir is taken once daily, preferably at the bedtime. So alternative when TLD is not suitable for the patient, if there is renal dysfunction, tenofovir cannot be given. In that case, abacavir is preferred. Women of childbearing potential not willing for contraception, counsel about the dolutegravir risk and benefit. Dolutegravir is still preferred. So on rifampicin, if on TB, continue TLD but add dolutegravir 50 mg 12 hourly after regular dose. That is 2 times a day. Dolutegravir is given twice a day instead of the single once daily regimen. In a case of non-tuberculosis patient, hepatitis B co-infection must include tenofovir and lamivudine. These two are must. This also covers the hepatitis B treatment. So follow-up of patients on antiretroviral therapy, monthly evaluation of weight, symptoms, TB screening, the adherence of pill count and self-reporting, the screening for opportunistic infections and immune reconstitution inflammatory syndrome in case of tuberculosis. CD count measured every 6 months initially, once stable yearly after suppression of viral load. So look for viral load remission at 6 months, then 12 months, and then annually. The goal is to keep the viral load less than 1000 copies per ml. You can go up to a target of 50, less than 50, which is a highly comprehensive and achievable viral load target. So you have to check for CBC, LFT, creatinine periodically, and lipid profile yearly. So antiretroviral therapy toxicities. These are main highlights of the commonly used drugs. There are a lot more drugs are used and side effects. These are the must to know and to remember the side effects. Tenofovir is very nephrotoxic, hence avoided in renal insufficiency. Abacavir is used instead. There is decreased bone density. Look for DEXA bone scan and look for osteoporosis also. In case of usage of zidovudine, it can cause megaloblastic anemia. Hence, look for peripheral smear and CBC count when using zidovudine. If it causing megaloblastic anemia, try to change the drug. It can also cause myalgia, fatigue, and neutropenia. In case of atazanavir, it can cause unconjugated hyperbilirubinemia. Abacavir has a potential to cause hypersensitivity reaction. Look for HLA B1507 and it can cause fever, rash, abdominal pain. For dolutegravir, it can cause nausea, diarrhea, insomnia, and it is hepatotoxic. So look for liver enzymes during monitoring. So darunavir and lopinavir, it can cause GI upset, hyperlipidemia, and glucose intolerance. The treatment failure summary: the viral load is more than 1000 copies per ml despite adequate adherence to drugs. It is called treatment failure. Immunologically, following CD4 count is treatment failure. Clinically, disease progression or new other opportunistic infection, if it is occurrence, then it's also treatment failure. So action: intensify adherence counseling. Switch to a second line. Atazanavir failure, switch to tenofovir backbone. Dolutegravir failure, look for boosted protease inhibitor based regimen. If protease inhibitor itself fail, then INSTI based regimen is preferred. So ART in TB co-infection, start ART within 2 weeks of starting ATT. And to avoid drug combination interacting with rifampicin is the main goal. Dolutegravir needs adjustment. Dolutegravir if given is usually given as 50 milligram once daily in case of HIV treatment. If it is coexisting with the tuberculosis, then it is given twice daily during rifampicin treatment. Continue extra dose for 2 weeks after rifampicin is stopped. So preventing opportunistic infections based on the CD4 count. Start at when the CD4 counts less than 350 cells on WHO stage 3 and 4. Stop when it is more than 350 cells on 2 visits 6 months apart. This is the perfect criteria. If CD4 counts are more than 350 cells at 2 visits at more than 6 months apart. The dose is sulfamethoxazole 800 milligram and trimethoprim 160 milligram once daily. That is Cotrimoxazole double strength dose tablet once daily. If in case of allergy, desensitize or Use dapsone. It prevents the pneumocystis pneumonia, toxoplasmosis, bacterial pneumonias, and isosporiasis. So TB preventive therapy in all HIV patients with no active TB, try to give isoniazid and rifampicin daily for 1 month, also called the 1 HP regimen. In case of pregnant and children, isoniazid therapy, monotherapy daily for 6 months. So post-exposure prophylaxis. Who should receive post-exposure prophylaxis? So known exposure to source confirmed with HIV positive fluid capable of transmission, that is blood, semen, enteral or sexual exposure to these kinds of patients. Source HIV status is unknown. Then also post-exposure should not wait for source testing. Need to give as early as possible. So as soon as possible when the exposure is identified, be given ideally within 24 hours. The maximum window is 72 hours. Earlier start is the greater efficacy. So the same drug regimen is given: Tenofovir 300, Lamivudine 300, and Dolutegravir 50 mg once daily. This follows the antiretroviral triple therapy principles. Alternatives can be Dolutegravir, Lopinavir, Altegravir. The duration is 28 days. The standard duration is 28 days for post-exposure prophylaxis. So hope you learned about the antiretroviral therapy that is currently recommended by the NACO and followed in the Indian setup. The standard really followed now the triple drug therapy for HIV nowadays is tenofovir, lamivudine, and dolutegravir once daily. If coexisting with tuberculosis, dolutegravir doses given twice daily. So ART has reduced HIV morbidity and mortality globally. Testing must be expanded for early diagnosis. The viral load monitoring is the essential to maintain suppression. So HIV care integration with non-communicable disease management is highly necessary, and ART remains central to ending the HIV epidemic. We'll try to end the HIV together before 2030. Hope you learned a lot in HIV management. This is Medicine Beyond Horizons. Thanks for watching.